If we zoom in and dive right past the skin, we enter a dense, tightly packed biological ecosystem. The abdominal wall is an exceptionally thin barrier. This anatomical quirk provides a direct, tactile window into the gastrointestinal, renal, hepatobiliary, and vascular systems. In the chest cavity, a rigid cage of ribs blocks direct physical access. Here, with the patient lying supine and relaxed, a clinician's hands can directly manipulate the internal organs. Extracting diagnostic data from this space requires treating the abdomen as a mechanical system governed by fluid dynamics, acoustic resonance, and respiratory descent. The clinician's hands operate as precision biophysical instruments, reading the live mechanics of the internal environment. For most of the human body, clinical examination follows a strict systemic sequence: inspection, palpation, percussion, and finally, auscultation. This diagram shows how the abdomen demands a strict inversion of that standard order. Here, you must listen, auscultate, before you ever press or percuss. The rationale is entirely mechanical. The moment a hand applies force to the abdominal wall, it physically alters baseline bowel motility. Pressing creates iatrogenic artifacts. The pressure artificially triggers peristalsis, flooding the cavity with sound and instantly corrupting the acoustic data you were trying to gather. That artificial noise masks the hyperactive sounds of an early bowel obstruction or the total silence characteristic of peritonitis. Reversing the standard order acts as a defensive protocol. It protects the integrity of the acoustic data before physical force has a chance to ruin the physiological baseline. In deep palpation, the clinician does not dig down to find solid organs. They use the patient's breathing to push the organs into their waiting hands. During inspiration, the diaphragm contracts downward. That physical descent forces structures like the liver to move inferiorly. For obese patients, we adapt using the hooking method. Fingers curl under the right costal margin, intercepting the liver's edge as the descending diaphragm forces it into their fingertips. In a healthy child, the spleen is tucked high beneath the ribcage and is too small to reach. Because it only becomes palpable once it has enlarged 2 to 3 times its normal volume, any spleen felt during an exam is a definitive marker of pathology. As the spleen grows, its mechanical trajectory is unique. It doesn't enlarge straight down, it expands diagonally, aiming directly toward the right iliac fossa. To intercept it, we use the Middleton maneuver. The examiner slides their left hand under the patient's back to support the posterior ribcage, while the right hand palpates upward along that precise diagonal path. Detecting movement along this specific diagonal axis during respiration provides definitive proof. It identifies an enlarged spleen rather than a static renal mass. Organ palpation relies entirely on vector interception. You map exactly which direction an organ will be driven by the respiratory engine and position your hands in its inevitable path. This dynamic tracking fails when the abdominal cavity floods with massive ascites. A thick accumulation of fluid creates a physical barrier that completely obscures normal organ palpation. To bypass this, we use the dipping method. The examiner applies a rapid, perpendicular force straight down through the fluid. Because liquids resist sudden compression, a quick thrust temporarily pushes the fluid layer laterally. Before the liquid can rush back in to fill the void, the solid organ underneath rebounds and taps against the examiner's fingers. For kidney swellings obscured by tissue and fluid, we use bimanual ballottement. By placing one hand posteriorly and pushing sharply, the solid kidney is physically bounced through the intervening fluid into the anterior receiving hand. When fluid blocks access to the anatomy, the clinician pivots to active, rapid mechanical displacement to expose the structures hidden beneath. The physical exam enables the clinician to quantify fluid volumes accurately without medical imaging. To detect moderate ascites, volumes hovering between 500 and 1,000 milliliters, we rely on Hutchison's shifting dullness test. This leverages acoustic physics. When you percuss the abdomen, empty space sounds like a hollow drum, tympani. As the patient rolls onto their side, gravity forces the fluid to pool in the dependent flank. When you percuss that same area again, the resonant note shifts from tympani to dense dullness. If the fluid accumulation scales up to gross, massive ascites of 1.5 to 2 liters or more, we switch to the fluid thrill or fluid wave test. By striking one flank, you launch a powerful kinetic wave that travels through the dense liquid medium inside, crashing against the opposite flank's boundary. However, executing this accurately requires an assistant to press the ulnar edge of their hand firmly down the midline of the patient's abdomen. This midline blockade is essential. Without it, the physical strike sends a false positive vibration traveling entirely through the superficial fat of the abdominal wall. The hand blocks the surface ripple, ensuring the wave you feel is strictly traveling through internal fluid. By manipulating acoustic shifts and kinetic wave transmission, an examiner turns their hands into precise volumetric sensors. Mastering the physics of the abdomen allows you to perform rapid, high-stakes pattern recognition. Subtle external signs immediately map to deep physiological failures. If you observe gastric peristalsis rippling visibly from right to left and hear a succussion splash on auscultation, you have a definitive physical map to an infantile hypertrophic pyloric stenosis. If you detect board-like involuntary muscle rigidity combined with a total absence of bowel sounds, the mechanics point to a catastrophic perforation and resulting peritonitis. Vascular patterns provide some of the most definitive systemic correlations. Notice these dilated superficial veins radiating away from the umbilicus, a presentation known as caput medusa. When you pair that visual finding with an audible venous hum, you confirm Cruviel-Baumgarten syndrome. It is a direct readout of massive internal portal hypertension. This comparative table synthesizes our advanced diagnostic framework. The hooking method targets the liver using respiratory descent. The Middleton maneuver intercepts the spleen along its diagonal trajectory, and the dipping method targets ascites via rapid fluid displacement. The abdominal exam is a dynamic process of mechanical interrogation. It is a rigorously structured extraction of biophysical data. By understanding the first principles of how organs move, how fluid transmits energy, and how acoustics shift, a clinician turns the human hand